All right, we can start right now. Assalamu alaikum. Good evening, everybody, and welcome to another session of Suhub's Excellent Saturday, our weekly spotlight, where we bring outstanding experts from across the globe to share their knowledge, their experience, and also clinical insights with our vibrant medical community. You know, Excellent Saturday is a part of Suhub's commitment to building stronger, more connected communities across various medical subspecialties and specialities. And yes, you can learn more about this by downloading the Suhub app from the Apple Store or Google Play to explore all of the benefits like job matching, professional networking, communities, etc. Today, we have a very exciting webinar, and we're delighted to welcome Dr. Ashraf, who is a highly skilled ophthalmologist with over 16 years of experience in the healthcare sector. Dr. Ashraf is currently serving as a consultant ophthalmologist at the Specialized Medical Center Hospital, where he previously led the ophthalmology department. We're so excited to have him with us today to dive deep into his area of expertise. And of course, after the session, we'll have the floor open to question and answers. So feel free to raise your hand, unmute yourself, or you can even drop your questions in the question and chat box. You can even ask anonymously if you prefer, if you want. And now, without any further ado, Dr. Ashraf, it's a pleasure to have you. You please go ahead and take the floor.
Assalamu alaikum wa rahmatullah. Thank you for Suhub for this invitation, and thank you all for attending this online webinar. It was difficult to choose the topic, and I chose this topic: how to optimize cataract surgery outcomes with the choice of intraocular lens. It's a bit complex issue, but we'll try to simplify it as much as we can. Record, please, your questions at the end, then we will discuss and answer some questions. The topic ended to be very long, so I will try to run through the slides and focus mainly on the topics that I think are of most important. As all you know, that the cataract surgery has changed during the last 10-15 years, from becoming surgery to restore vision to surgery that has refractive outcomes, and it also addresses cataract, refractive, and near vision. Patients' expectations also have changed during the last years. Now the patient wants to be fully independent of the glasses. He expects clear vision all through the visual tasks he performed. So the objective of this talk is to introduce you to the different models of intraocular lenses, what are the advantages and disadvantages of each model, and how to tailor and optimize the results of your cataract patients using these lenses to get the best outcome. There's also a question: what is the ideal IOL? There's really no ideal IOL. Each patient needs his IOL to be tailored according to his needs, to his requirements. But there's no one size that fits all patients. The goal of IOL selection is mainly to get the patient satisfied and to meet his expectations. If we have an overlook of what IOL there's in the markets, you will have different categories that we will run through. The first category is the monofocal IOL, and as you know, the monofocal IOL focuses light and vision in a single point, like you see in this model graph A, where the light, all the light is focused on one point. And this spherical monofocal IOL has itself got advanced by the introducing of the aspheric IOL models, which improves contrast sensitivity and improves vision. The monofocal is very sharp for distance, and it is free of halos or glare, but the problem is it's a limited range of focus and the need for the use of glasses for near vision. The next and the main step of this advancement in IOL technology is the introduction of the bifocal or the multifocal IOLs, which could give us a free sight without the need to use glasses, which addressed presbyopia. The multifocal IOL has different technologies, but the main principle that the lens in the this kind of IOL, instead of focusing light into a single point, this IOL focus light into more than one foci. Here are 2 in the bifocal model and 3 in the trifocal model, and this will give the patient a vision at different distances. The main principle of the multifocal IOL is simultaneous vision. And what we mean by simultaneous vision, that the retina will perceive more than 2 images, and the brain will choose which image to look at. If you look at this picture or drawing, you can see 2 old faces looking to each other, but if you see this gentleman playing guitar and the other one wearing a hat, your brain can choose which to look at. And that's almost the same that happens with the multifocal IOL. This adaptation to this perception of 2 images is called neuroadaptation. The multifocal IOL has themselves different types. Mainly we divide them into refractive and diffractive IOL. And the main difference between the refractive and diffractive is the pupil dependence. The refractive depends on the size of the pupil, while the diffractive models are free from the dependence on the pupil size. The diffractive trifocal IOL are the latest advancement, and here's a long list of these IOLs. It focuses the light into 3 spots, which corresponds for far vision, intermediate vision, like using computer, and reading for near. Myself, I use mainly the Panoptics, the Symphony thickness, which we will discuss the advantages while we go through. Another type of trifocal IOLs and advancement in the multifocal are the Ray 1 Galaxy, Alcon, Panoptics Plus, and Odyssey, which are expected to reach the market soon. The multifocal has advantages that they could give you a free from glasses from all the distances, the near and the intermediate and the far, and they are convenient for almost the daily activity. But there's a trade. The main trade is that the patient will experience some visual compromises, which we call dysphotopsia, and they are in the form of glare, like this one, halos, which is a ring around the light, or starbursts, which usually starts at the early after the implantation of the IOL. And we will discuss later how to choose a patient who should end up with the least amount of these photopsias. The other issue with these lenses that they could not give excellent vision at low light, like reading and under dim light, and they have issue with contrast sensitivity. That's the trade for the multifocal IOL. Another type of lenses which we see during the last couple of years is a principle called extended depth of focus. And if we try to understand what's the difference between extended depth of focus and the multifocal, is to look at this drawing for the multifocal IOL. We will see that the light is focused into 2 points. And it is seen also here that this is the first focal point and this is the second focal point. But instead of that, the light is put into a long tube of focus, an elongated focus. If you see here from infinity until like 60 centimeter, it is a continuous focus without the surrounding halos. And this is the main advantage of these lenses, that they reduce halos and glares in comparison to the multifocal IOL, but the disadvantage that they lack the near part of vision. Different types of EDOF in the market, mainly the thickness pure C, the Alcon Vivity IOL, and different models that will cover this category. The advantages of the EDOF is their less dysphotopsia, less glare and halos, and the continuous focus from intermediate to far. But their problem is that they lack the near vision. The last category that we will talk today is something which is between monofocal and EDOF, which is we call monofocal plus or enhanced monofocal. And the main example of that is the thickness enhanced lens, which in this lens there's a central increased curvature area, which is continuous. There's no sharp edge between this area with increased power and the surrounding. So it's a smooth, continuous change, but it doesn't reach to the level of the EDOF. And this lens will have the same characteristic of the monofocal IOL, plus it will give the patient some advantage at intermediate distance. In my practice, I shifted from implanting monofocal IOL as the primary lens if the patient doesn't want any EDOF or multifocal, to implanting enhanced monofocal IOL, which will give the patient some advantage on the intermediate distance without compromising the far vision. You can see in this diagram that the patients who are questioned about the visual function with 3 types of enhanced monofocal, that they performed well with intermediate vision tasks. So if we want to compare the lenses all together, we will find that if we evaluate the patient for the uncorrected distant visual acuity, we'll find that the monofocal are the benchmark for this distant vision, though some studies didn't find any difference between the multifocal and the monofocal and the EDOF even for the quality of the far vision. But the best one for far vision is, of course, the monofocal IOL. If we look at the intermediate distance, and by intermediate distance, we are talking about mainly the computer screen or anything like 66 centimeter. And so the EDOF and the multifocal IOL are the best in this category. They are better than the enhanced monofocal, and it is the 3 of them is better than the monofocal IOL. While in the near visual task, like 33 centimeter, the multifocal or the trifocal are the best in this. EDOF usually gives a slightly better vision for the reading distance, better than the enhanced monofocal or the monofocal. So if we compare evaluate these lenses from the prospect of spectacle independence, which means that if we implant a lens which will give the patient freedom from glasses, of course, as you might thought that multifocal, which give the highest glasses independence across all the lenses, while monofocal is the least one. And if we compare the side effects of the lens in prospect of dysphotopsia, the glare, and the halos, the monofocal are the best one, followed by the enhanced, and at the end of the list is the multifocal IOLs. This is a screenshot from one of the simulators on the internet for the multifocal IOL. This is a multifocal, and if you see that the patient can see the dashboard, which is the intermediate distance, and can see also the far, but if you look at the spotlights here, you see some shadow and halo around the lights. If you compare it to the monovision, which has a very sharp light spots in the far and very sharp image for this car, for example, but the dashboard and the screen here is not clear at all. It's clear with the EDOF, but without the sphotopsias. And the enhanced monofocal has a better intermediate vision than the monofocal without the also the sphotopsia. You can yourself log into let's say Johnson & Johnson or Alcon Visual Simulator to compare with the results of the lenses. If we compare the satisfaction of the patients, how the patients are satisfied, you will find that it is different really depending on the patient's preference and expectations. So if you have a patient and you want to decide which lens to use for him, we need a systematic approach to this patient so that we can help the patient decide what is the best lens for him. The key steps in reaching that objective is to, one, have a detailed preoperative evaluation. You need to evaluate your patients thoroughly, listen to the patient, examine every aspect of the eye, which we will talk in details in the following slides. You need to talk to your patients, discuss, explain to the patient what is the advantages and disadvantage of each lens, listen to the patient. You should also do the best surgical practice that you can do to minimize any drawbacks like inducing astigmatism or removing any opacity on the posterior capsule. That's a way to improve your surgical technique to give the patient the best vision possible. And as your patients in the post-operative period, need to listen to the patient, listen to his complaint, try to address if he's satisfied, not satisfied, why he's not satisfied, and try to solve this issue. So it's a multi-step that needs your full attention and meticulous work to reach a happy patient at the end. So how to evaluate a patient for a multifocal IOL? First of all, you need to hear from the patient that he has a strong desire to be spectacle-free. Okay, you need to ask the patient, listen to the patient that he's very eager to be free of glasses. And one approach, I usually ask patients at the beginning of the interview or when we discuss which lens to use, is ask the patient if he would bother using reading glasses. If he says, "Oh, doctor, I don't bother. I don't worry. I don't bother using reading glasses after surgery." So usually I go for the monofocal plus or the EDOF or the monofocal. I exclude multifocal because I didn't sense in his talk that he wants to have a multifocal IOL. But on the other hand, if a gentleman or a lady, they tell me, "Doctor, look, I'm so bothered with this glasses. I want to get rid of the glasses," then I would consider to have a multifocal or EDOF lens in the list of choice for this patient. The other thing is the patient should have a realistic expectation. Realistic expectations means that the wants of the patient are within the capabilities of your lens that you will choose to implant for this patient. You need to listen to the patient and ask him about his lifestyle, what is his hobbies, what does he do in his free time, reading computer, playing, for example, outside. He likes to walk. Does he do a lot of night driving? These things will help you decide if the lens that you will provide or the patient choose will serve his needs. One thing that you can is do a visual behavior analysis. Give the patient paper, tell him, go for 2-3 days, write me exactly how much time you spent on each work, near, intermediate, far. What did you do during the last week, for example? Try to know exactly what's the main patient need. Is it for reading? Is it for intermediate? Or is it for far? Ask the patient occupation. Is he an airline pilot? If he's an airline pilot, I would less think of multifocal because of these halos and glares, and also for patients who are truck drivers. For the pediatric patients, there's a controversy going on about if you should implant a multifocal IOL in the pediatric cataract. The consensus is toward not implanting a multifocal IOL for the risk of amblyopia in these patients. Then, after that, you need to examine your patients, see what's refractive they have. Are they hyperope or myope? Hyperope patients usually are so happy with the results because you got them free from the reading glasses or intermediate glasses. You need to do a very excellent biometry to using the latest technology to try to get the accurate biometry to choose the right power for your patients. Should do the patients a corneal topography with Pentacam or whatever machine that you have to evaluate for the cornea. Imagine this fact. If I want to implant an IOL for a patient who's, I'm thinking of trifocal, let's say the best one, I would like to do it in a perfect eye, an eye that is free of any scars or irregularities in the cornea or any even previous surgeries. One thing to consider is the astigmatism. In those IOL and premium IOL and multifocal EDOF, I would implant an antoric lens if the patient astigmatism is less than 0.7. If the astigmatism is 1 or more, I would plan to treat the astigmatism, because this astigmatism of 1 diopter in an EDOF or multifocal will degrade the vision in this patient. The other thing is to consider what is your surgical induced astigmatism. And surgical induced astigmatism is that when you go inside the eye with your blade, you will induce astigmatism. How much is that? Is it important? It depends on the size of the wound, how much far it is from the center. Examine the patients for dry eye. Check if the patient has any blepharitis. Examine the patient's pupil. Examine the angle alpha and angle kappa, which references to the distances between the axes of the eye, the visual axis, the optical axis, and the center of the limbus to limbus. You collect all these informations, then you sit with yourself, see if the patient's parameters, which will not go deep into the details, and try to see if your patient fits in the accepted range, because it's easier to apologize for the patient, tell him that you are not really a good fit for a trifocal or premium IOL. It's much easier to manage than to manage an unhappy patient after surgery. Other aspects of ocular evaluation is to screen for any other comorbidities, like is the patient diabetic? Is the patient having glaucoma? Is the patient have an optic nerve disease? Those patients are not really a good candidate for a premium IOL. Regarding the biometry, you need to be very accurate in your post-operative results within like 1.5 or 1.25 diopter from the metropia. How to achieve that? Use the latest technology. Choose your formula. Some formulas are good for short eye, for long eyes, and there's formulas for post-refractive surgery. Always don't try to memorize which formula is good for what. You can, from with the tip of your finger, just write what is the best formula for short eye. Okay, and do the calculation according to that formula, and use more than one formula at the same time. One of the good websites that will serve you is the Icarus IOL calculator, which will do the IOL calculation using different IOL formulas, and for different eyes, like post-refractive surgery or a patient with keratoconus. Evaluate, compare the results, and then choose what number you think that is good for the patient. Going back to the patient's wants and needs, is very important to address the right outcome for the patient, because patients who will need to do a very neat near work will have a different choice from patients who are interested more in intermediate vision or in far vision. Always discuss, listen to the patients, explain to the patients. The main issue which you should train yourself to is to be an educator for the patient rather than a person who's marketing a lens. You should listen to the patient needs. Tell him that this lens might serve your needs more. Explain to the patients the glare, what is the glare, the halos, when he would expect them, if he would tolerate them, and if they would interfere with his life. Show the patients the prints, kit prints in your clinic. Show the patients how much is the fine prints, and don't talk to the patient in an abstract way. Like, you tell the patient, look, you will have some glare halos and you will see the fine font. No, show the patient exactly what are you talking about, and let the patient know that, as I said before, that you are educating him, giving him information rather than you are selling him a lens. Other consideration in alternatives for the multifocal IOLs is to have something called monovision. Monovision means that we correct both eyes with a different post-operative target, like targeting minus 0.75 to minus 1.5 in the non-dominant eye, while targeting emmetropia in the dominant eye. So both eyes will work together. This works well with the enhanced monofocal, or EDOF as an alternative for the trifocal IOL. And as we said before, that you should target to correct the astigmatism by either limber relaxing incision or using the EDOF. Another way is something called mix and match, which means that you implant an EDOF lens in one eye and a multifocal lens in the other eye. Those things we said were the surgical technique. We talked about that you try to be as precise in your operation as much as you can by creating a clear small wounds, creating a round, well-measured centered capsular X's, remove the OVD very well. All these things will guide you toward reaching a good results for your patient. What about post-operative care? Before you do the surgery and while counseling the patient, tell the patient that we are using calculators to predict what post-operative refractive error that you have. In like so and so in 95% of cases, we are very accurate, but there is 5% of cases that we might be out of this range. If we are out of this range, we might need to do other procedure to address this issue if it arises, like doing a PRK or LASIK. Discussing these things with your patient before going to surgery while the patient's in your office will save you a lot in case of any incidents of complications that could happen post-op. It's not nice to hear from the patient that, doctor, you didn't tell me about that. Always think of all possibilities that could happen. Inform the patient, get his consent for this before proceeding to the surgery. Tell the patient that about the neuroadaptation, which means that your brain will get used to the use of these devices, which is the IOLs, and it needs time. And if you didn't adapt to these lenses, we might sometimes need to remove and exchange. One thing that after implanting a multifocal or EDOF lens with those patients is, if you have an unhappy patient and you would see the capsule after that, the posterior capsule, and you decide that this discomfort or this dissatisfaction is due to the opacity in the posterior capsule. My advice is not to rush into doing posterior YAG capsulotomy. Every effort to understand what is going with this patient. Is it related to dry eye? Is it related to the centration of the IOL, a tilt, a misalignment of the lens before going to the YAG laser? Because this could be due to other cause. Because if you do YAG laser, these patients, it would be difficult to remove and exchange your lens. Thank you for your time and for your listening, and we are ready to receive questions.
Thank you so much. Thank you so much, Dr. Ashraf. It was very informative and very detailed. We truly appreciate your time and your presence and your expertise. Thank you so much. Please, if you have any questions, you can definitely raise your hand, and Dr. Ashraf will be ready to answer. Dr. Ashraf, you can stop presenting so that you can see the entire screen. Is there any question? You can raise your hands. Anybody? I think you received a couple of the anonymous question and answers. Yes. One of them said, how do you manage patients who are indecisive or have unrealistic expectation about post-op visual outcomes?
As you know, if the patient is having unrealistic expectation, I would consider implanting monofocal or monofocal plus for this patient. Most of the patients now are well educated. They have read about this topic, and they know what is multifocal, what is EDOF. If you feel that the patient is more eager toward implanting these lenses, you might advise him to take a second opinion, for example, but don't be so enthusiastic into implanting these patients if you think that the patient is have unrealistic expectation.
Definitely. Thank you so much. Anybody who can ask, definitely you can. Okay, we have Ahmed. You can unmute yourself and ask Dr. Ashraf directly. تفضل. You're on mute, yes.
Good evening, Dr. Ashraf. Thanks for your nice and fruitful lecture. I would like to ask you, when addressing patient with astigmatism more than 1.5 diopter, would you consider double head surgery? I mean, would you go for LASIK to correct the astigmatism, then go for multifocal, or you go for multifocal toric from the start?
I would prefer to go for multifocal toric from the start, because when you correct the astigmatism with laser, you will induce high order aberrations. And the multifocal lenses are very sensitive to high order aberrations. I would do either limbal relaxing incision. If I usually use the calculator by Johnson and Johnson to use for limbal relaxing incision, or better to have a multifocal toric IOL for this patient.
What about the result with the multifocal toric in your hands?
I really didn't implant too much number. I have a couple of cases with multifocal toric. The result is not really as good as the multifocal. Multifocal without toricity is much better in the outcome than multifocal toric. And the reason is something, I think it's related to the design of the lens, but not related to any residual astigmatism.
So the recommendation to avoid them?
You need to be pushed very hard by the patient to go for multifocal toric.
Thank you very much. Thank you.
Laugh, no. I cannot hear you, Doctor.
Thank you so much. Thank you so much, Ahmed. There's another question from Omar. You can participate and unmute yourself. Yes. Yes, Omar, I think you can accept it and unmute yourself to participate. Okay. Can you try accepting it again? Okay, meanwhile, he accepts it. There's another question for you, Doctor. Is from your wide experience, Dr. Ashraf, with the newer generation of EDOF lenses claiming reduced halos and glare, how do you evaluate these claims in real-world settings?
I think it's fact that it reduces halos in comparison to trifocal. If you compare it to the monofocal, there's maybe slight halos, okay? But if in comparison to trifocal, I usually I ask my patients directly, okay? Because if you explain to the patients before surgery, you will have halos, you will have glare. You will not be shy to ask them about after surgery if they have halos and glares. Okay, I ask the patients directly if they have halos, glares. I show them even the simulator, and I'll try to ask them to rate how much halos and glares they have. And most of the patients with the EDOF reported no halos or minimal halos after surgery.
So much. Thank you, Doctor. Any more questions? You can raise your hands. You can definitely ask. Today is your chance to learn from his wide experience. I think you have another question in the Q&A here. Is in the borderline cases, do you ever consider mixing and matching lenses, such as the monofocal in one eye and multifocal or EDOF in the other?
Yes, I have a few cases, especially if the patient did a monofocal maybe years back. I would tell him about the new technology, the EDOF. I think there's no problem in matching any two kinds of lenses, as long as you explain to the patient in details. I remember recently I matched a patient who has a 10 years trifocal lens in one eye, and I implanted an EDOF in the other eye, aiming to have a continuous vision, because If you remember when we talked about the trifocal, the issue with the trifocal is that the patient will tell you, look, doctor, I go to 330 centimeter, it's clear. If I go 40 centimeter, it becomes slightly blurred. If I go to 50 centimeter, now it's clear again. And if I go beyond, it will be blurred. So if you implant an EDOF with this trifocal, you will have a continuous vision, which I think the patients would appreciate.
Definitely. There is a question from Mohammed Asayed. Please feel free to unmute yourself. تفضل.
السلام عليكم.
عليكم السلام.
السلام ورحمة الله وبركاته.
First eye, patient trifocal well and good. Second eye, vitreous loss. Try to implant 3 pieces successful, but monofocal.
Okay.
Your opinion?
I think you managed it very well if you implant a monofocal in the other eye, because the trifocal lenses need a very well centration, and there's no sulcus trifocal IOL in my hands, at least to my knowledge. I think you did a great job to implant a monofocal IOL in the other eye. Complications could arise with any doctor, and if you inform your patients that we plan to implant a trifocal, but there's another complication like vitreous loss or capsular rupture, you would go back to the primary management of these complications, and the best thing is to implant a sulcus IOL.
I hope that answered your question, Mohammed Asayed. You're on mute. المايك مقفول.
Thank you.
You're welcome.
Allah.
Any more last question? We can take one last question from the audience before we wrap up. You can raise your hands and you can unmute yourself, or you can drop your questions in the chat box below. Let me check. Yes, there is one that says, how long does the neuroadaptation typically take in patients receiving the EDOF or the multifocal IOLs?
Usually it's months, okay? Give yourself 3 months, even up to 6 months, until you feel that the time has passed enough to give the patient time for neuroadaptation. It is, you should also, the doctor also should be patient. The doctor and the patient both should be quite patient, waiting for the neuroadaptation to happen.
Excellent, excellent. Thank you so much, Dr. Ashraf. And thank you so much for your time and your valuable insights you've shared with us today. We truly appreciate your expertise and the practical knowledge, of course, you provided. Yani, it was an excellent session. And I'm pretty sure everybody learned so much from you today. And thank you, everybody, for attending who joined us today. Your participation and engagement, make these sessions even more enriching. And yes, please take a moment to fill out the feedback forms to help us know how the webinar went, what could we improve, and what to do better. And don't forget to download the Suhub app to more interactions and to check our next webinars. But until now, thank you so much, Dr. Ashraf. We truly appreciate it and your time and your presence. شكرا جزيلا دكتور. تسلم. إن شاء الله.
Thank you very much. Thank you for the opportunity, and thank you, Suhub, for this opportunity.
الله يخليك. تسلم. Thank you, everybody. مع السلامة. شكرا.